Here we are, part 2, chapter 14 of the medical overview. And before I hit the next slide, I'm going to warn you, I didn't time this lecture, but it sure seems appropriate. Because we have to talk about the diseases that we're going to run into. Recognizing that we will likely deal with patients who are carrying some type of communicable and infectious disease. Today, tomorrow, for the next forever, it'll likely hit your mind that it's COVID, but there are so many other diseases that we deal with on a daily basis. You treat these patients the same. You approach them like you would any other medical patient. However, your personal protective equipment and body substance isolation is going to be different. I hope you're wearing the right stuff. Any non-pandemic day, you're going to have what you need. You're going to do the same assessment and same history that you would for any other medical patient. You're going to follow sample and baseline vitals. And we need to make it our habit at this point to ask about travel history. We're working with our 911 center so that becomes a standard question. But if it hasn't been asked by the dispatcher, you need to ask it. This helps you understand where they may have come into contact with whatever it is that's making them feel bad. Is it a tapeworm? Is it a bot fly? Is it Ebola or coronavirus? All have some sort of issues associated with travel and certain areas. You need to focus on any of the life-threatening conditions. A patient with an infectious disease isn't necessarily calling 911 because of the infectious disease. You need to treat the complaints, and you need to use your standard precautions. There is a difference, I tell you, couldn't have been timed any better. There is a difference between an epidemic and a pandemic. An epidemic is a new case of a disease in a human population exceeding what is expected. So when the coronavirus was only in China and it was growing to larger proportions, it was an epidemic. The minute it exploded into a global outbreak is when it became a pandemic. H1N1, which we originally called the swine flu, was present for many years in animals before in 2009 it was found in humans. And so there was that animal to human transmission. It raised that increased awareness that we are seeing mutations of diseases in animals, making it more susceptible to human transmission as well. Anything that can be passed by the respiratory route, so influenza and coronavirus, you've got to protect yourself. This starts by placing a surgical mask or a non-rebreather on your patient, and then wearing appropriate PPE for yourself. So gloves and eye protection, and if you have it, a fit-tested N95 mask. It's also important to consider getting the flu vaccine. And while it's not going to protect you from all of the strands, it is going to be based on whatever the highest rate of flu strain was found in the previous year. So it is a tool that's out there to help protect your immune system. You might come across a patient who has herpes simplex or herpes. Most of them are asymptomatic. You do have to be cautious, though I would hope you wouldn't be having close personal contact with your patients. It may, however, cause an open wound or infection around the mouth or the nose. It causes symptomatic infections in the lips and the genital area. So it can lead to more serious illnesses in those patients who have compromised immune systems. The next infectious disease is HIV. And we face a huge risk of exposure to HIV, especially when we are dealing with patients who are expelling bodily fluids, so blood, urine, feces. It can be fatal. There is no vaccine, but we're reaching a point where the drugs can mitigate the disease and allow you to live a very long life. If you have an exposure and the testing is going through, one of the things you have to consider is whether you want to take the antiviral drugs, because that can help mitigate the likelihood of the issues associated with the disease. But there's some negatives associated with that as well. So, when in doubt, be cautious. Try not to become exposed. Prevent any potential exposure by using appropriate PPE and good methods. You may not know your patient has HIV. If they don't tell you, you might not be aware. It's not like they're going to necessarily show that they have it because they may not show any symptoms. So you have to use precaution on every patient. Wearing your gloves, being prepared if you're working around the mouth, anything with the respiratory system, having goggles and a mask on as well. Another infectious disease that you're going to deal with is hepatitis. Hepatitis is inflammation of the liver, often as a result of an infection. Some of the early signs of hepatitis: loss of appetite, vomiting, fever, cough, fatigue. They mimic other diseases. You will see that list of early signs in so many other diseases, and we won't know it's hepatitis. Your patient, if they've never been diagnosed before, may not know either. What will tell you is the later sign. So a patient with hepatitis whose liver is in late stages of hepatitis or significant outbreak is going to be jaundiced. So they're going to have yellowing of the skin and of the whites of the eyes. There's no way to tell which hepatitis patients are contagious, but hepatitis B does have a vaccine, a series of 3 shots, and it is highly recommended for the EMT. There are 4 types of hepatitis, so A, B, C, and D. And you can see in table 14.2 the different routes of infection and incubation periods, as well as some of the treatments and various comments. One of the things to keep in mind is hepatitis A is that fecal to oral infected food or drink. So fecal matter gets on food that is eaten. And it is a chronic condition. It is not a chronic condition, and there is a vaccine available. Hepatitis A, the body actually clears the infection on its own. So, if you got to get a hepatitis A, if you're going to get an A on a test, the hepatitis test is the one to get the A on. You may also run into meningitis, and I told you all the story about inappropriate PPE and having to get medication. Meningitis is inflammation of the meningeal covers of the brain and the spinal cord. So it's an infection in the coverings of the brain and the spinal cord. So because it's an infection, you're looking at fever, headache, stiff neck. So they used to always say, if you can't touch your chin to your chest without severe pain, that's a sign of meningitis, and then altered mental status. Forms of meningitis, bacterial and viral. Viral is not contagious, but bacterial is. The best thing to do is take your standard precautions and respiratory precautions as well. If you do treat a patient with meningitis, you definitely want to document it and let your infection control officer know. We don't hear about tuberculosis or TB a lot, but it is still around. So this is another one of those that as an EMT, you might be exposed to it and you might get some of the level of infection, but it doesn't trigger an issue. So if you've ever had that titer test where they've come in and they've either kind of injected a small bubble under your skin or pricked you with the 4 tines, and then you had to go back within 48 hours to read it, that is a TB test. And if it is an active disease, then you are going to be contagious, and that's when it's in your lungs, and it's a respiratory TB. And we think about the tuberculosis cough. So you can go look it up and look up tuberculosis when it was really a big concern. But you can also test positive for TB, but be inactive. And a lot of EMS providers have done that to the point they get lung x-rays every year just to monitor the level of infection in their body. But they're not actively contagious. It's kind of like having a light bulb and a light switch, but the light switch is off. Something's got to come in and turn that light switch on to get the light bulb to work, and it's the same way with the disease. Infectious agents can take hold in some patients more easily, immunocompromised in the elderly patients. So, one of the reasons we tell people they need to be healthy as well is, while your health is important and top priority, if you are sick and you transport an immunocompromised patient, you increase their risk of infection as well. So there's no real 100% protection, no vaccine. It's crazy to think that 1/3 of the world's population is actually infected with TB. Preventative therapy is the most effective, and monitoring whether or not you've had an exposure is really a top priority. Next is cough or pertussis. You've probably seen a lot of commercials here more recently because as the push from the anti-vacciners has come through, we've actually seen an increase in whooping cough again, which is really a huge concern because it had basically disappeared. Whooping cough includes a fever and just kind of a whoop sound. So you get into a coughing fit, and then as you come out of a coughing fit, you'll whoop as you breathe. And the best way to prevent exposure is the vaccination. There is a pertussis vaccination. If your patient sounds like they could have it, then you both should be wearing a mask because whooping cough is a respiratory issue. Oh, this is a nasty one. MRSA, MRSA, and you can read on the screen the full term, but MRSA is a staph infection. MRSA can be transmitted from patient to patient. Just if you go and touch a patient and then you go and touch another patient but you didn't wash your hands, you can actually transmit MRSA that way. It is an antibiotic resistant infection, which is a huge problem. And MRSA is just, it's gross. There are some factors that increase the risk of MRSA: prolonged hospital stays, being in intensive care or burn unit, and exposure to a person who has MRSA. You see it as a soft tissue infection that causes abscesses and sepsis and septic shock in older patients. There have been cases where MRSA has gotten so bad that they end up having to cut out areas of the skin just because they can't clean it up to try to prevent it from spreading. Some other issues, and again, the timing of this couldn't be more inappropriate. So MERS-CoV is a version of what we're going through now that showed up in Saudi Arabia in 2012. So it's a different strain of a coronavirus that came from the Middle East, caused very similar symptoms as what we see, but it didn't have the transmission or the fatality rate that some of the other versions have. It was a global health issue and a huge concern about spread, but ended up not being as big a problem as first anticipated. And then you probably all remember Ebola. Ebola was our last outbreak concern. An incubation period of 6 to 12 days, symptoms not appearing for up to 21 days, watery diarrhea, vomiting, fever, body aches, and bleeding. And it was a fatality rate of 70%, or up to 70% if it didn't have prompt treatment. And we did have people, and plenty of people, who survived it, and they were working on vaccinations and treatments. Some of the problem that came in Africa as they tried to share this is the belief that the government was coming in and was actually reinfecting the people. If you plan to interact with patients who have traveled, or even you yourself are traveling or working in an international setting, you've got to consider your patient's travel history. Like I said, there's no acronym yet that includes travel history, but it needs to become a question you just second nature ask yourself. Because we are seeing such being able to travel the world is great, but it is exposing us to medical issues that we might not have previously thought would be a problem. Asking questions such as, have you traveled? If so, where? Do you know if anybody else in the party is experiencing similar signs and symptoms? Even if it was just to Mexico, did you drink the water? Because, Montezuma's revenge, causes of gastrointestinal issues in a patient if they've drank dirty water from a country where it's not the greatest water source. All important questions to ask of your medical patient. Just to kind of wrap this chapter up, assessment and treatment of your medical patients can actually be really hard. Your chest pain isn't always a chest pain. Your difficulty breathing isn't always asthmatic. And you've got to be kind of a sleuth and a detective and ask the right questions to figure it out. And you've got to consider the fact that your patient may have more than one issue. Especially as we get older, we tend to have multiple medical issues that could potentially be compounding each other. And that there is your overview of your medical patient.